All right. Yeah.
Thank
So we're
you.
just going to keep things rolling here. I swear that was like my neck is sore from nodding in agreement so much with Mark and Selena. It was pretty much like Mark and Selena's greatest dry eye hits right there. I was like singing along the whole time. So, I mean, that was an amazing way to really kind of set everything up from the beginning here. And now we're going to take a bit more of a bent when we're looking at the aesthetic side of things. So, with aesthetics, I always find it interesting because so often, and I'm sure Selena, you get this sometimes, how often has a patient told you, well, I don't want to be vain, but they start with there's almost this like guilt that they have. Yeah, they are almost apologizing for something. And I'm like, never apologize for that. I'm like, I'm probably way more vain than you are. But realistically, to me, we all want to look good. Like that's the thing, whether we want to admit it or not. And so often we've created this false dichotomy between function and aesthetics. Most of the things, if you look at that we consider attractive traits, they're signs of health. So that's really what we want to remember about this is it's kind of unraveling these two things that just because you're talking about aesthetics doesn't mean you're not helping them function better. And that's kind of at least how I like to think about the aesthetic side of things. Because when I describe my clinic, it's a dry and ocular surface disease clinic. I don't even talk about aesthetics, but they're intrinsically part of this because again, I don't really see much of that divide.
And that's how I even got into aesthetics is like I started to pull this dry eye thread, and the more that you pull at it, the more that they're just intertwined, and there's really like no differentiation. You kind of have to at least have some working knowledge, not that you're maybe going to do all of the things, but you have to know how they work together.
Absolutely here. So that's pretty much going to be how we're setting everything up to start here. And again, financial disclosures again, and everything has been mitigated, which we've established is very important. And like I was talking about at the beginning, when we're talking about the importance of function for this. So the one thing I always think about when it comes to what we consider attractive. So when they asked both men and women what the most attractive feature they thought was in general, it's the eyes. And that's universal. And the reason for that is because, you know, they all say eyes are the window to the soul, everything like that. But really, it's because from an evolutionary standpoint, it's how we communicate. So much of our emotion, so much of our intention is dictated by our eyes. When you look at someone's eyes, what do we talk about with communicating? It's make eye contact. And why is that? Because that is where most of our nonverbal communication comes from. So we're always focused on the eyes. So doesn't it make sense that if someone feels like their eyes aren't looking how they want them to be, if they're red, they got the droopy eyes, the tired eyes, of course that's going to bother them because that's how we communicate with each other.
Let me ask a question. How many people in here do aesthetics in their practice? So a couple. How many of you fit contact lenses? How many of you fit frames? Or like have frames in your practice? Guess what? You're already doing it. You're doing aesthetics. Like no one chooses a frame to put on their face because they don't care about the way they look. I mean, I got a double bar on and like this is one of my favorite pairs, but if I want to look different, then I choose a different frame. Nobody's putting a piece of plastic in their eye because they love the way that feels. Yes, part of it's because of function, but a lot of it is because they don't like the way they look in glasses, right? It's just thinking about this differently. We already do this. It's just expanding on that knowledge.
Yeah, I love how you always bring that up because I never really thought about that, but I know when we said this before, I love that point of contact lenses. You're already doing that. For many people, it's function, but most people, it's like, I just don't like the way I look in glasses. Or how many of us have had like the little kid who comes in and they're malingering because they want to wear glasses, right? Because they want to have that way that they look.
I had a 10-year-old that came in with a monocle. His dad was like, I need you to stop this. I was like,
it's not a phase. It's who I am. When are you going to just accept me for who I am, Dad?
Gosh, I know. I was like, oh.
He's going to be a CEO someday.
Exactly.
He's going to be like, Dad didn't want me now. He's laughing, Dad.
Yeah, exactly. Like.
And then the ocular surface, again, Mark and Selena already kind of set this up. And Selena, I know you added this, but I love this point that you have here that the eyes are more than just for adornment. They're not there just to make them look pretty. I mean, they're naturally pretty, but at the same time, there is the visual function side of things. So we have to balance the two as well, because sometimes we do want our eyes to look a certain way, but you don't want to swing too far and go the other direction where you're now sacrificing function and ocular health for that cosmetic look that you're really going after.
Yeah, and there's so many things in mascara that can be a problem, formaldehyde, and donors. There's, fiber lash that's made out of nylon that winds up like embedded into the conch. There's people that are putting serums on to, grow their eyelashes. And, we know that most of them contain a PGA, and that causes meibomian gland dysfunction. So, and then of course the whole lash extension and false lashes and all of that piece that breed blepharitis and Demodex and all the things and latex and the glues. And so it is a good reminder of that they're not just for adornment. They're there to keep things off of the ocular surface. But if you make them too long, it actually creates a vector onto the front surface. And so now you're bringing things onto the front surface because of the length of the lash. So, and people just, there's so much there that they don't understand because just lack of education.
And that's a big point too, because we always think of the lashes mainly from that cosmetic perspective. And we're like, oh yeah, they protect the eyes. But Selena's point there is one that I feel like even we as optometrists often forget, is like their exact length has that. If they're too short, then the air stagnates. There's airflow dynamics. It's the more you look at the ocular surface, I'm in awe of how everything has to work perfectly. And even things that you wouldn't even think, like that lash length and how air dynamics and airflow is over that. It's just incredible. But it really lets us know how, like, if you want to get into the weeds with this, you can get into the weeds. And I often do. And I spend my Friday nights looking at PubMed because I have a rollicking social life. But yeah, so it's really just amazing how you can look at how intricate this all gets. And really every element of the ocular surface we talk about here has this specific function. And then again, here, we've pretty much talked about most of this before here. These are all the things that we're going to be dealing with. Specifically, though, with eyelid disorders here, that's a major part of what we're looking at when it comes to that aesthetic side of things and lashes. Now, we know all of this goes into it, but most of the time, I feel like when you're thinking cosmetics, most of our patients are talking about the bottom three.
Yep.
Redness, how their lids look, and how their lashes look.
I had a fun patient that came in. He was a self-dry eye referral. And his wife was with him. And she's like, you've got to help him. His eyes are so red. He's miserable. And I looked at him and I pulled his lids up. And I'm not kidding. Like when I pulled him, like they practically like went over his forehead. And I asked him, I was like, so do you have sleep apnea? Do you sleep with a CPAP machine on? And his wife is like, how did you know that? And he's like, yeah, I do. And she was just like, oh my God, like she thought I was some kind of wizard.
I love that.
She's like, you like really know what you're doing. I was like, oh, I hope I do. But she thought, and he'd had a bleph already, and she thought his bleph had failed because he had floppy eyelid syndrome. And the reason that happens is because they're hypoxic and that connective tissue actually changes. So it's a physiological piece, but it's not something we want to miss. But patients not only care about how they look, but the complete functionality of what's happening there too.
And that is such a big point. I always bring up with floppy eyelid syndrome because I don't know about this, but for some reason, when it comes to health history, patients never mention sleep apnea. They'll tell you they're diabetic, they'll tell you they have hypertension, but for some reason, it just completely leaves their mind. And you mentioned that.
Yeah, and I have on my entrance questionnaire, I have 3 questions about sleep apnea. Do you snore? Do you wake up with a headache? And do you feel like you have to take a nap in the afternoon? They answer yes to all 3 of those questions, and they haven't been diagnosed with sleep apnea. They need a sleep study. So we are because it's so underdiagnosed, to your point.
There's an estimate that 3 billion people in the world have sleep apnea. It's probably one of the most underdiagnosed conditions. And the thing about this isn't like a minor thing. This can lead to congestive heart failure, all kinds of things, stroke. So this is one of the biggest things. I always say, lift the lids, physically manipulate the lids, because like Selena said, you basically can pull the eyelid up over their head when they have this floppy lid syndrome. And to your point, it's actually really sad in this case, because if this patient would have been diagnosed, they would never got that bleph.
Yep.
Because a blepharoplasty is not the treatment for this, because it recurs, because the end problem is still there. So when I think about this, I'm like, oh, great. Some of the patient already had their lids operated on for something that wasn't even going to do anything for them.
Yeah.
All right. And then here, these are the things, this is how it's described to us. So this is kind of where you have to speak the language of your patient, right? Because they're not going to come in, they're going to be like, well, I have a mild ptosis and, I have some dermatochalasis going on here. You have to understand and interpret what they mean when they say, my eyes look tired. Right. That's one of the biggest ones I get. And tired, dark circles, or they're like, something's going on with my lashes. Then the glassy kind of eyes, they just always say that. My friends ask me, are you tired?
Yeah. Yep.
That's one of the big things for that too. I always get.
And then the dry eye patient that's like, people are like, why are you crying? Like that's a huge one.
Oh yeah,
right?
yeah.
Like,
why are you always patting at your eye?
Mhm.
Or then
Are you okay?
Yeah, people have I don't know why they always go to this for the redness. They're like, are you high? Are you high?
Yeah.
And it's always my elderly patients too, for some reason. It's like everyone's 70 plus. They're like, my friends are like, are you high? I'm like, oh, the eyes are red. I don't know why you're going to that. I don't know. It's Woodstock, apparently, again. I wasn't told that this was coming up again, but apparently that's where their mind's at this point. Maybe, when you're retired, you have a bit more recreational time. I don't know.
But if they're doing redness reducing drops, and so many of them are, a lot of times, those are compounding things because
Yeah.
they're not choosing a good redness reducing drop. It's got a rebound and tons of preservatives.
And they're just in this vicious cycle again
Yeah.
here. So then, this is one of your patients. Can you
Yeah.
mention what's going on here, especially with this one? Because I think this is a great example.
I mean, and it's just a great example of like, immediately when you look at that person, what are you going to ask? What do you know about this person? They're using some kind of serum, right? And that's all you have to ask. Like your lashes are really like noticeably long. Is that normal? Or are you putting something on them? That's all you have to ask, because then they're going to tell you, oh, I'm using blah, 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 blah. And then when you go into the details of, okay, so let's talk more about what's actually in that's making that happen, then they don't understand. I mean, one of my classic patients, not this patient, she had had dry eye for 10 years, type 1 diabetic, had been to like 5 or 6 different doctors. She was miserable. And she's like, my dry eye is just horrendous and I cannot function. Please, can you help me? She'd driven like 2.5 hours away. And before I did anything, I took one look at her and I said, what are you looking at? What are you putting on your lashes? And she goes, what do you mean? And I said, it looks like you're using some kind of serum on your lashes. And she said, yeah, I'm using blah, blah, blah. And which I knew had a synthetic prostaglandin in it. And her point, and she was well educated, she said, well, yeah, but you guys use that in ophthalmology and optometry for glaucoma. Like it's perfectly safe. And I said, it's perfectly safe for glaucoma, but there is a known problem that it causes meibomian gland dysfunction and dry eye. And she was horrified. And she'd been on this for 10 years and she was so mad. She's like, how is it that I have been to 5 or 6 other doctors and not one person asked me that question? And we stopped it. And we went up doing IPL because she's got horrible rosacea and a whole bunch of other things going on. But just that one question, man, was a game changer.
And what that really highlights is this misunderstanding that patients have. What they don't see, it's like, well, use it for glaucoma, but that's because what's the other thing? Vision loss.
Yep.
They don't understand that there's trade-offs for these things. Just because we use it doesn't mean that it's going to be perfectly safe. We just know, well, the alternative for you is vision loss. So these patients don't necessarily see those nuances. That's why I say she do just enough to hurt herself.
Yep. She knew that exactly, just enough.
Yeah. And that a lot of times is dangerous. So we have to have these conversations with patients so they know this. And the other thing is, half the time, these aren't going to be prescriptions.
No, they're over the counter.
Yeah.
And because it's a synthetic prostaglandin, it doesn't have to go through the FDA process. And so you're going to look for an ingredient called isopropyl cloprosinate, which is usually going to be buried about 30 ingredients in. It's not going to be the active ingredient because they know not to put it in that label. So, a lot of times the active ingredient is hyaluronic acid and aloe vera, very benign things that sound great. And then you look about 30 things down and it's isopropyl cloprosinate. And the big one that I talk about is that periorbital fat atrophy. You can't undo that.
Yeah, that's when you get that hollowing effect.
Yeah.
It's really tough, and patients a lot of times will be like, was there anything we can do about this? And it's
like,
you always hate when, because we all want to help, so we always hate when we're kind of like, well, not a whole lot we can do for that. Yeah.
I have a question. What lash serums do you like? Are there ones that you like recommend?
So anything that doesn't have a PGA in it, that's polypeptide, lipopeptides, I'm okay with. And I will still prescribe Latisse, but I do it in a very different way than I used to. So I make them sign a consent form if they understand the risks and benefits. And then I follow them every 3 months, and we're doing dry eye testing every 3 months so that we don't miss anything and let something go for a whole year. I mean, and this happens. I had a 13-year-old that was on something that her friend had given her, and her mom didn't even know that she was using it. And she's 13. So it's just rampant across any age group.
Yeah. And then actually, ironically, again, when you mentioned that, Caitlin, DNL actually, I don't know if you guys saw this, they actually launched a line of basically more cosmetic focused products that have been like safe to use around the eyes, and they actually do have a lash serum, which is one that I've been recommending. And I kind of let patients know because they recognize BNL as kind of like, oh yeah, they do like my contacts, or they do something like that. So a lot of times I'll recommend that just because I'll tell them this is specifically formulated to be safer for your eyes, which is the term I often use with things in general. It's safer. Safer is probably your best term because that doesn't mean you're going to be like perfect. And just like Selena mentioned too, I'm very careful because I consider myself very pragmatic. I know my patients are going to want to do things. It's not dry eye and all these problems take away so much from our patients' lives. If it's important to the patient, it's important to me. And if they're like, well, I just really want my lashes to look a certain way. So again, my whole policy is let's make this safer.
Right.
So when I have them use like Latisse, one thing I'm like, make sure that it's only on the lashes.
Yes.
You pat away you don't want it sitting anywhere it's not supposed to be. So I'm like, lashes, and make sure if any drips anywhere else, you're getting rid of it. And I would rather have you accidentally wick more away than what you need than to let it sit there. And I'll show them pictures of that hollowed out orbit, because I'll be like, this is what can happen.
And, he brings up a really good point about contact time. So, when you look at ingredients across the board, it also matters contact time and how long it's on the skin. Something that you wash off is different than something that you're going to leave on overnight. So that plays a role into this too. And we could really get in the weeds on that, but just a note there.
And then here are just a lot of the things, again, we typically deal with. Again, you guys all have this, so this is more for your information here. Just that hollowing, excessive pigment, vasculature, all these things are things that you're going to be dealing with when you're within that aesthetic realm of
And
things
if
here.
your frustration was like mine, when patients ask, hey, what about these dark circles? And you're like, this study really helps you answer that question, because it is actually one of the most complicated questions to answer.
Yes.
But this will help you drive to be able to answer that question.
And what Mark mentioned earlier today, which I'm a huge fan of when it comes to inter-optometry, inter-referrals for this, just because you don't do it, it's good for you to know what can be done and then who does it. So I am a huge proponent of just not kind of shrugging your shoulders, but just because you do it, your patients, I'll tell you this, how many times have you sent a patient out for like an RD repair or something like that, and you're the hero? You didn't fix it, but you're the hero because you found it. So if you, just because you find it and get the patient to where they need to go, they will be so grateful for you. So that's what I would say. Just because you're not going to deal with it, at least know what can be done, because that's the information the patient really needs. And then again, we just go back to it's just functional concerns here. So the top one is one of my patients. And this one here, we'll talk a bit about this later. We've already kind of hit with that lag ophthalmos, everything with this. This is a great picture of what I call inferior scleral show and lid laxity with age, because you can see it's even uneven. It kind of swoops down at the edge here. Yep. So this is purely an aging change with this patient, that the lid has lost its tonicity, that elastin is degenerated with age. And this is going to fundamentally disrupt blink mechanics. Like Selena, she nailed it so well with this, is that our blinking is critical to meibum secretion, tear renewal, and all of this. So this natural aging change is going to completely disrupt tear dynamics. And not only that, look, you can see there, because I have the stain in there, you can even see the tears are kind of sitting up there more. And these patients often will have epiphora because the eye is trying to just basically compensate for this.
Well, and look, like the puncta is not even flush, like it can't drain.
Exactly,
right?
Yeah.
It's tipped forward. And then what else does the patient have?
Exactly, this is the big thing too.
Blepharopigmentation, that they've unintentionally probably destroyed how many meibomian glands because the tattoo needle punched through all of those glands when they delivered that pigment. So there's a whole lot, and then look at all these telangiectatic vessels. Like we could talk about this slide for.
Yeah, this image is worth 1,000 words. And this patient, she was pushing 80. And the funny thing is when I asked her, I'm like, oh yeah, because I always mention like, oh, and I see you have tattooed eyeliner. And she's like, oh yeah, I do have that. I got that years ago. Half the time they forget. But again, this slide is basically, when I think of like a patient with cosmetics, with aesthetics, all these changes, this is a perfect example of that.
And if patients ask, and you a lot of times don't get the opportunity for them to ask before they do this, this is always a no for me, along with lash tint and lift. That's always a hard no.
Yeah. So now we're going to actually go into treatment options. So now that we kind of know what's going on, again, what can we do about all these things? And this is why I love doing this lecture with Selena, because like she is my go-to for like the in-depth procedures, because I do a lot of them, like we'll talk about IPL, RF, a lot of things like that. But once you get into the really cool advanced stuff, that's where Selena has just really been able to run with things. And I know your clinic, you told me, has just really taken off with like the aesthetic side of things.
Yeah,
as well.
it's a fun, it's just a fun pillar of our practice that lets us practice in a different way. And I'm lucky enough to be in Oklahoma, and so we have a broad scope. And so I started doing neurotoxin, I don't know, 8 or 9 years ago. I added laser resurfacing 3 years ago. We're doing RF with microneedling now. Like there's a lot that you can do in that space that's really cool.
And even with that advanced stuff, I'll tell you what I've been doing with just even IPL and RF is astounding from that. And I actually call them, again, my focus is dry, but I call them the happy side effects. And patients love that. I'm like, well, one thing is they normally ask me like, well, are there going to be any side effects of the IPL and the RF? I'm like, it's really bad. You're going to look younger. Your eyes are going to be like tighter skin around them. Like, it's just awful. I normally get a laugh. And the funny thing is, even patients who are miserable, when I tell them that, they're normally like, I'm in. Like, that's the thing for that, because it shows you like, and I actually had, I was having a conversation with one of my girlfriend's co-residents, her husband, and he's in internal medicine. And we were talking about how so often patients, like if they need a procedure that's medically necessary, they're like, well, I don't really want to pay for any of this. But the minute there's a cosmetic component, they're like, yep, out of pocket, I'll pay for it. He told me, he kept talking about how his belly button was just too prominent. He's like, is there anything you can do about this? My belly button just pushes out and it bothers me too much. And the guy needed a heart procedure. And he's like, well, I'm here to talk about the heart. He's like, but the belly button, the belly button though, but I can't see my heart. So it's just this weird thing, but it shows you again, that psychological aspect of it again for this. So, but like I said, if it's important to your patient, it should be important to us. And again, these are basic things. We'll talk a lot about like lid hygiene and elements with that, because I think that's like the foundation to a lot of these cosmetic things, because still you want things like omega-3 fatty acid supplementation, which is just generally good health nutrition habits that help set a good foundation for the aesthetic side of things. Whoop. See if there we go. Okay, and what's going on here then, Selena?
I mean, how many people in here do wide field photography? Lots of us, right? So what do you see on that image? Right? You can't even see the full picture. The patient can't fully see out completely functionally because you've got eyelids sitting in the way, right? And then, this patient, we're looking at meibography, but dermatochalasis, good heavens, you've got skin like literally sitting on the lashes. So the reason I share this is because there's a lot of things that we're doing already in the clinic. It's just that we don't think of it in that way, but there's opportunity here to have a conversation. And my technicians even will notice this and go, wow, do you feel like your lids are heavy? Are they droopy? Like I'm having to like pull this up so I can even get the image for Dr. McGee. And so it opens that conversation to having that aesthetic like piece. And so many of our patients don't understand that there's a difference between a cosmetic bleph and a functional bleph. If it's just blepharoptosis, we can do oxymetazoline. So there's a lot there. It's such a different conversation. And I probably do, I don't know, maybe 1 to 2, 3 referrals a day on a bleph consult.
Oh, absolutely.
Patients have no idea that they qualify for that, or they're like, I've always wanted to have this done. I didn't know this was even a thing.
And I'll say, I'm like too, and sometimes this does go into that functional element. I'm like, do your eyes feel better? Like if you like lift them up, they're like, oh yeah, they just feel better, because they do have that added pressure when they have very prominent dermatochalasis. The lids are just sitting and they're pressing. And imagine you have a dry surface and you already have friction. Now you've put a weight on top of that. So now it's blinking over an already dry surface with additional weight. And I've had patients, I'm like, yeah, if you lift this, like, oh, my eye feels so much better. So it can be functional, and it can also be a comfort thing. So,
and like they'll kind of hide it too. I mean, to his point, earlier he's talked about a lot of patients come in saying my eyes are tired. Well, are they tired because they're using that frontalis muscle and they're recruiting to pull all that up? And like if you push all that down and make them sit there, they're like, that doesn't feel very good. So there's like a lot of ways to like tuck that into how you examine patients.
So again, it's kind of learning to speak their language and interpret that. So that's just things like listening to patients and trying to pull out exactly what's going on for them could be a key to this. And then like Selena was talking about here, Upneat can be great for when you want to make sure you don't have anything like, myasthenia gravis, anything major like that. Always, when it comes to lid things, I always do quick screening questions. I think one of the big things that you've heard from Mark, myself, and Selena here is these don't need to be long drawn out conversations. I will say you should be able to 30 seconds, 60 seconds max for anything. This shouldn't take up a lot of chair time. If there's like a new ptosis, obviously I'm looking for things like a third nerve palsy. So I'm looking at positioning. If it's unilateral, if they tell me my eyelids are heavy, I always ask them, I'm like, okay, well, first of all, do you ever have any trouble breathing, swallowing? Because if they do, they're already at pretty advanced myasthenia gravis. The other thing is, I'm like, do you feel like your lids just go down like this and you can't lift them up? They'll know those things. A lot of times they're like, oh no, they just feel droopy. But I always use those as a screener because it's very easy to overlook some of the important things. So just when you're in this realm, don't make sure you overlook things like that.
I mean, the key things that he brought up, is it unilateral? Is it sudden onset? Is there pupil involvement? That's going to keep you out of trouble.
Yeah, so just make sure when you're doing this that you don't get too caught up in just the cosmetic appearance, that you're thinking about the underlying cause. And again, assessment here, we'll kind of talk about this. Again, you just got to look at the lids here. You see, we've got some really good images of Demodex, so we're just going to, I mean, we're going to get hit with that hard today. So
I'm going to bring up one point, just the way that I examine patients, because used to it was like this, and that top left corner, I just, had patients, I'm looking at their lids and their lashes and we're looking straight ahead. The moment that you have the patient look down, look how much more you can see. And this is 10x, 16x, 25x. I just put that on the exact same patient. I like 10x. 16 I could live with, 25 is too much because I can't see the forest for the trees. And then straight ahead, I can't see anything at all. So just doing that one simple thing of having the patient look down and then identifying what's happening at the base of the lashes. That's why I share that. And then this one is a picture of lash extensions. So if you're not super familiar with that process, this is helpful because it's the anatomic lash that's glued onto, or I'm sorry, the fake lash that's glued onto their anatomic lash. And sometimes it's hard to tell if it's glue or is that a collarette. And like this picture, that's glue because there's a gap between. A collarette's going to come crawling out of the orifice of the hair follicle because that's all the waste products from Demodex. So I think sometimes this is just good to like really understand what you're looking at. So that's why I shared this picture.
Yeah, and that's a great thing for that because I get the same question a lot. If it's from Demodex, it's going to be chilling around the follicle. That's the thing. If it's going up more, it's normally debris. It can be scurf. That's technically the differentiator there. So that's a good thing here. Artificial lashes, you're always going to see some form of debris. It's just par for the course for that. And then here, I think we've hit a lot of these things here, which is really good there. Again, we kind of talked about this again here. The patient that Selena had that shows you here.
Oh,
this is right here a really good thing to look at because Selena nailed this. This will be hidden.
Yeah. So the only way, so when you're in the computer, the only way that you see this is if you click that button. But this is the one that everybody sees, the hyaluronic acid and the aloe vera. You have to physically like push that to look at all the other things. And then what we're like 30 things down, there's your active ingredient, isopropyl glufosinate.
Yeah. So the thing to remember for this is these aren't FDA regulated like our prescriptions are. Think of these are basically more so in the class of like dietary supplements. And what I always tell everyone about it was like, I used to get my protein on bodybuilding.com because they would always give you lots of samples and they were the sketchiest samples in the world. And I would always call it pre-workout roulette because I didn't know what was going to happen when I used it, which was part of the raw thrill of everything. So I always remember
I'm a little worried about you, Corey.
Oh, it was so much fun. I always remember the one time I got one and it was definitely from like Russia because it was in Cyrillic. And I'm like, I have no idea what this is going to do, but I'm going to try it. That was an experience for sure. But that was where I think that was the closest I felt like to going towards death. Like my heart was just like racing and everything. And like, I like broke, like my back got all flushed. And I'm like, well, this is how I die. But at least it was kind of fun for that. That's what I think about for this. You don't want to take a sketchy Russian supplement with your eyes the same way that I did for that. So I was a little bit younger then, but it was a good time. But we don't want that for our patients either.
Oh.
So again, something we've already kind of talked about here a lot too is that lotilaner, which is Xdemvy, is a really good option for Demodex. Mark and I will talk about that more in depth later today. And this is just kind of taking a look at everything here. And Selena mentioned this earlier. So get the red out drops. This is an area where I even know now it's still kind of controversial amongst doctors. I think there's a lot of debate with this. Even patients I know a lot of times are wary because they've gotten the message that they shouldn't be using this, but all redness relievers are not created equal. So for me, the difference I look here is we have the old school ones, we have Visine and Clear Eyes, and then what I think about as a modern one is Lumify, which is bromonidine. There is a fundamental difference between these, and it's the target of these. So the biggest thing is these old school ones are going to cause rebound redness. You don't see that with Lumify, with brimonidine, and the reason why it's where they target. Because Visine and Clear Eyes, these are going to target the arterial side of things. And they're going to constrict there. But why are we worried about arterials? Because that's the blood flow supply coming in. So you're potentially getting less oxygen with that. You're cutting that off. But what happens is a lot of times, as we know, when we get that constriction of arterials, they rebound. And then you get this sudden perfusion of oxygen. And that's where you get that rebound redness. Whereas the target of brimonidine is the venial. It's the return side. So that's why you're less prone to be getting that rebound redness. And Selena, I'd like to get your opinion on this. For me, I'm very, again, pragmatic, and I know that redness, cosmetic redness is a concern. So yes, I do want to treat the underlying cause, but patients sometimes need something, especially for like, oh, I'm going to a special event.
Yep.
I have no problem telling them, you know what, I would recommend you use Lumify. However, don't try to overuse it because there's a preservative in it, but they're going to find it. And I've had patients, that's a game changer for them. My favorite thing to do is if they haven't used it, I'll actually put a drop in an office, and then they always get the, oh, when they like look at the mirror, when they kind of have that reaction to it. And a lot of times they're like, this is amazing. My eyes haven't looked this good in so long. So to me, I know there's different schools of thought, but I'm all for it. So how about you, Selena?
Yeah, I mean, I just think they have to understand not to abuse it. And
Yes.
and they are working on a preservative-free version,
Yes.
so coming soon, which I will be very happy about.
Yep, that's what I've been waiting for years.
Yep.
So when we have that, I mean, still, it's like treat the underlying cause, but that's going to allay a lot of the, the downsides we can get with that preservative exposure. Also, how many of you have ever heard of the eye whitening procedure, bright white? Yeah, I'm not surprised. Yeah, so Caitlin has seen it because I've seen it here. Have you? Yeah. I hope those of you who have not seen it never do. It's basically a procedure where they remove the conjunctiva. Basically, because what they're doing is they're stripping the vessels away because they're like, well, your eyes can't look red if you don't have any vessels. It's basically butchering the surface of the eyes. Yeah. I've had one patient for it, and the poor guy had the worst ocular surface I've ever seen. Those vessels are there for a reason. That's where we get nutrition. That's where we get the immune function for this. So yeah, his eyes looked white, but his corneas were terrible. Trashed. So always avoid that. So patients, again, remember, this is why you have to take every complaint of cosmetic things seriously, because these patients will look, they'll Google and they'll see this. And, our patients, I don't know what the mindset is. They always ask, was there a surgery I can do? I don't know why, but I just, it's human nature. They seem to be, is there a surgery? Is there a surgery? They'll come across this and they'll be like, oh my gosh, this, because I've actually looked up the website for it, and they make it sound like it's a magical procedure where nothing bad's going to happen. Like your eyes will be white. You'll never have to worry about any of this. And once you've seen it once, that's far too many times. Yep. So just be aware that that exists. And if a patient ever brings it up, steer clear. And then basically here, let's talk about retinol, Selena, because I feel like this is a good specific topic, because we've kind of talked about, we'll talk a bit about preservatives, but I want to start with retinol because I think that's something we're all going to have questions from our patients about.
Yeah, and there's different versions of retinol. And so when you look at the actual prescription of retinoic acid, that's the one that has studies behind it that actually says, yes, it's turning over the skin faster. It does help with cell differentiation, and it does make the skin look better. Patients have to wear sunscreen, but we also know that retinoic acid attacks the meibomian glands and it can destroy them. So there's lots of different products that are over the counter that are either retinol aldehyde, retinol, and retinol AL. So with each version of that, it has to go through multiple steps to get to retinoic acid. And these products are wildly expensive, and they can destroy my meibomian glands. So if I have a dry eye patient and they talk about retinol or retinoic acid, I tell them absolutely not. If they're not a dry eye patient and they want to use it, I just tell them to stay 2 finger widths away from anywhere around the eyelid, because I don't want that migrating into the meibomian glands and causing a bigger problem.
And that's exactly what I tell patients with this, because again, I ask them point blank, I'm like, are you going to use it? Like I even tell them, I just want you to be honest with me, because at the end of the day, that's what I want. I'm like, I want us to have an honest dialogue, because I know there's going to be some patients who, even though I tell them the dry risk, they're going to use it. So I'm like, if you are going to use it, I say exactly what Selena does. I'm like, okay, compromise with me. That's kind of what I do. I'm like, okay, so if you're going to use it, keep it that 2. Sometimes, a lot of times, if they do have dry, I say 3, just to try to keep it there. I'm like, keep it below here, 3 eye. I'm like, that will be our deal. You can use it, but you keep it from around the eyes because, I get it. We want to work down here, but let's make sure that we keep this safer for the eyes. So again, I am very much, I'm like, I never want my patient to feel like there's any judgment, anything like that. I'm like, cards all on the table here. I just want us to all be on the same page, and we'll find something that's a good middle ground for this. Then the preservatives for this. We've talked a lot about this, but I always say if you want dry eye doctors to get in a fist fight, put them all in a room and have them debate cosmetics. I swear, because everyone has an opinion on it. It's an area we're evolving, but I mean, so for me, I'm actually like, I think I really should dabble and get myself some makeup, and I want to like try it on myself because I have experience with everything else. So I'm like, Halloween's coming up. I have a good excuse for it. I mean, Joanna could obviously walk in on me. I'm like, I swear this is research. I swear.
It's research.
This is research.
Sure.
Research. That's why I'm using your products here. But it's kind of getting an idea and a feel for everything yourself. And one of my big things is some people for this, I think, and I'll see what you like to think for this, Selena. I think not consensus, we're not there yet, but I do think a lot of us are thinking outside of a few very bad actors that we do want to avoid. A lot of cosmetic use isn't the wearing of makeup itself, it's lacking the full removal of it. Yeah. It's that contact time. Yeah. It's not like if you're going to wear it for a few hours, it's when you look and you still have that leftover debris because it's staying there over time. So that's often what I tell my patients. I'm like, okay, so here are the ingredients I recommend. You can use those, but make sure you remove it entirely, because at least that's where I think you get that chronic inflammation, is that constant, the fact that it's there constantly. Same thing with preservatives. There's a lot of preservatives that are relatively benign. They're still needed. You don't want to put something that could possibly be contaminated on the eye. But again, I'm very much about removal.
Right. And if you want to like take a deeper dive, I mean, I got to be part of the TFOS lifestyle workshop that was on the subcommittee for cosmetics. And we spent 2 years doing research on cosmetics, like that was actually like published literature. And what I now know is we know some, but we need way more studies and we need more regulation. So there's some things tucked in here that will help you, but that paper is very helpful.
Yeah.
And that's where this comes from.
Yes.
So yeah. And then this is just my version of this. This is not TFOS. This is no one else. This is just my version.
This is really good, by the way, though, guys. This is Selena put together, in my opinion, one of the best summaries, especially for those of us, like I said, for a lot of guys in the room, myself, who weren't familiar with cosmetics. This is fantastic.
Because we go through these courses and it's like, well, great, you told me all the 50 things I can't do. Can you please give me something that I can? So yes. Yep. Yes. Yep. And answer for them.
Yeah, and want to give them a handout or something.
Yes.
That conversation always comes up.
Yep.
Tell me to take it off, but what's something that I can use?
Here's, so her question is, for those of you that are online that can't hear, her question is, she carries a lot of things for like lid hygiene in the office, as far as hypochlorous sprays, as far as cleansers, probably a micellar cleanser, stuff like that she already carries. But patients always ask, okay, well, what mascara can I use? What eyeliner can I use? Do we have specific brands? So some of the ones that I feel like are very safe are Eyes of the Story. I love their eyeliner. It's like a Sharpie pen. It's awesome and it's easy to get off and it doesn't flake. So that's my favorite eyeliner. And then they have mascara that there are 3 tubes in one package, which I like because it makes the patient throw it away once a month. And then I like Thrive. I like Ilia has some good products. Those are kind of like my 3 go-tos that I really fully understand, like the ingredients that are in them. So those are kind of my 3 that I recommend to patients. So Eyes of the Story, yes. The other 2, no. Question. Oh yeah. As a no. Yes. So her question is, I don't have magnetic lashes on here. Why do I not? I need to add it. The reason I don't like magnetic lashes is because the eyeliner itself is iron oxide, which is toxic to the front surface. The second reason is I have an N of 1 that a patient used them. And when you take the magnet, the idea is the lash has a little magnet that sticks to the iron oxide that's painted onto the eyelid. Is all of her skin came off with it when she took off the magnet. Exactly. So that is a hard no, and I will add that on here.
And then why don't we like iron, Selena, around the eye?
I mean,
Let's think about that, right?
let's think about
Why
that.
don't we want iron?
Why?
Because what's another thing that we're routinely get called in on a Friday night to like take care of? Oh yeah, I was welding. I was working on a car and I got some metal in my eye. And what do we get? We get the rust ring. So
And
to me,
it oxidizes within minutes.
exactly. It's
Minutes.
So to me, I'm like, when I hear iron near the eye, I'm like, oh no.
Yeah.
That's a recipe for disaster.
I mean, and the other one that I took, so part of my part of the TFOS workshop was glitter. Holy, you guys, I know more about glitter than I ever want to know about glitter. There are different sizes of glitter. Depending on the size of glitter, it's considered a cosmetic or it's considered a food product. But at the end of the day, all that matters is glitter are tiny pieces of plastic that are spray painted that do not go away. So they wind up in either embedded into the conch or they wind up in the canalicular tissue and you can't get rid of it. So patients, no glitter. Shimmer, I'm okay with, but even some of the shimmery stuff, stick to pencils, not powders.
Too shimmery.
Too shimmery.
Too
It might
shimmery.
have mica in it, which is like little pieces of ground up stone, shells that are ground up. So shimmer and a pencil, better than glitter.
And then Caitlin, did you have?
Yeah, for eyelid makeup remover and like just eyelid wash in general, what's like a great one that you can point patients towards?
So I like a micellar water, not something oil-based. And I will have patients use the micellar water to remove their eye makeup and then do their normal cleanser behind it. Because some micellars actually I don't want it on there longer. There's a very popular one that's over the counter that advertises all the time, but what's left behind is residue that can be an issue. So I have them do their cleanser right behind it. So the same line that Corey was talking about with B&L's product, that Lumify line, they have a micellar cleanser, they have the lash and brow serum, and they have an eye brightening cream that's got niacinamide and caffeine. Those were all really well studied. Scope, somebody else mentioned, they have, oh my gosh, it's 7 ingredients, and it's even a step above micellar water. It's actually non-ionized water. And the way that it works is it needs to have a little bit of contact time so that it has a moment to tract all of that dirt and stuff onto the cotton swab that you're going to take it off with. So that's kind of just a tiny learning curve if you're going to use that one, but I carry that one in my office too. Those are my two favorite micellars, but for somebody that has very sensitive eyes, that one has 7 ingredients. There's nothing like it on the market.
Yeah.
So going back to conversation about what's important for the patient, if they're going to use these eyeshadows, from your perspective, what's that conversation like when you see the glitter in their film, and how do you approach that? Hey, stop using it.
Right. So her question is a great question. So her question is, what do you do? How do you have this conversation when you have a patient that you see they're doing something not right? And how do you approach that and say, don't do that anymore? Or let's, so I will ask them, do you tell me more about what you're putting on? And do you wear it every day? And then I will just give them reasons not to. So at the end of the day, patients will still sometimes, even with all the great education, they're still going to go, you know what, I don't really care what you say, I'm doing it anyway. The risk benefit to them is not worth it. That's okay. That doesn't mean you failed. Doesn't mean that you stopped talking about it. You at least gave them all the information. So that's how I approach it is, I want to know what the product is. How do they do this every day? Sometimes it's just habits. If they're doing something fun on Friday night, okay, well, do it on Friday night and just don't do that every day. Tight lining is a big one on eyeliner on the inside of right across the meibomian glands. And they have no idea they're putting that on 30 little glands. They don't even know what those are. So just those educational pieces. And I've had some good conversations on extensions, and I've won a lot of those conversations. They wind up taking them off. And there's plenty of them. They're like, I'm not taking them off. Just help me manage them the best that we can. And so we do it that way too. But ask good questions. Yeah. And luckily I have a 14-year-old and an 11-year-old daughter. And I have some mom wins as far as they both come to me now and they're showing me the label. Can I use this? Yes. So those are my 2 favorite wins of my kids don't use anything from their friends. They don't buy anything without me approving it.
Yeah. And another big thing for that, show them a picture. That's the big thing I'll do. when they see the junk, they see the glitter in their tears. They're like, oh, it's because it does not look good. Like it looks very unnatural when you see that shimmer. Like it's one of the things that there, but when they see it in the tear film, they can see under that magnification that they have these little foreign bodies. And like, and a lot of them will actually have a little bit of irritation. They won't even realize it, but they're like, oh, no wonder my eyes feel sandy or something like that. Because I'm literally blinking with this stuff in my tears. And so often, because I know both Selena and I are really big on using like imaging software and things like that, they'll think they've removed makeup and they're like, oh my gosh, I cleaned this morning, and they see the debris residue. So pictures, again, can be a huge thing for that. All right, let's see here. And then oral medications, we kind of talk about this too. So this is one of my patients. This is a pretty classic example of that. So we were talking about retinol, Accutane. We are the experts with Accutane. And the reason why I say that is because I've heard this from a dermatologist. The patient came in and they told me, oh yeah, my dermatologist told me it could cause dry eye, but once I'm off, I'll be fine. It will go back. Because they did not understand this. Their understanding was superficial, which is they're like, oh, dry eye can be a side effect, but they didn't know exactly what it was doing. They didn't have the knowledge of the meibomian glands, and they don't know that once that's there, there's no going back. So I always tell patients, I mean, that's actually one of my intake questions. Have you ever used Accutane? Because half the time that will explain why I see glands like this is because they cause these damage. And again, this is where we kind of have to step in and be the experts, because dermatologists are amazing with the skin itself, but like anything, there's just so much for them to know. It would be, you know, I'm not going to expect them to know everything about the eye the same way I'm not going to expect us to know every single detail about dermatology. But this is where we have to have that conversation, because so many patients are on this and they have no idea the damage it could be doing.
No, and like when I've gotten lucky on a couple of teenagers that the parents ask, hey, we're going to start this. They said it might cause dry eye. You know, what do we do? Should I do this? And so we still did it. And remember, these are sebaceous glands. That's what our target is for isoretinoid. So we just do serial meibography and serial dry eye testing the whole way through. So that if we start to see an issue, then we're gonna pause. But we also do interventional methods along the way to keep those meibomian glands functioning. They should be on an omega orally to help as well. So there's ways that you can do it in a smart way together.
Safer. That's if I could give you any takeaway, because I do the exact same thing from this. It's safer ways to do things. Again, because there are going to be some realities. I mean, for some patients, I can tell you again, you know, their acne it's destroying their self-confidence. It's doing all this. And like, I'm not going to be the one who say like, well, I get to decide what trumps this. You get to decide which thing's there, and it's finding the safe way. It's no different than like when you're testing for plaquenil. You know what I mean? When you're checking for any retinal changes, it's the exact same thing. Serial meibography is your friend for that. So again, you just let them know, you know, we'll watch this, but if we see some changes, we're going to be proactive. Then we know we might want to pull back or anything for that.
Once a month. So her question is, how often do I see them back? So I see them monthly while they're on it.
And a lot of times I'm a big fan of recommending courses rather than continuous use. I'm like, okay, let's start with 3 months, see how you do, and then pull back, see if you're good. So I like to keep set increments instead of this idea of you're just going to be using it, you know, forever, and we'll do this. I like to see how they respond.
Because sometimes they'll be like, I had a young lady that was 17 and she'd been on it for 11 months and she was a train wreck. She thought she needed new glasses, but not new glasses. So to your point, he's exactly right. Like just at least monthly, and then maybe take a break and see how they do. But I also see why we need it, because I have patients that are in their adulthood who were doing microneedling and laser things to fix acne scars. So you don't want to, it's like this, let's do it together.
Exactly. You just help them do it as safely as they can for that. Oh, this is a great case then. One of yours, Selena.
Actually, this was her.
Yeah, this is the example.
She's 17. And she'd been on Accutane for 11 months.
And this is your why right here. She
came in and her mom came with her, and she's like, well, she just needs glasses. She's having trouble driving at night. And she's like, I just can't see.
Yeah, this is how they end up in Caitlin's clinic actually for the sclerals, because basically with sclerals, Caitlin did a great job this morning of talking about the importance of that. And I'm sure Selena and Mark are like this too. So when I think of sclerals, for the most part, these are what I consider almost my like end stage dry eye patients, because they're at the point where I'm going to still be hitting them with every other thing. But when those glands are completely gone and everything, you basically have to recreate the ocular surface. I consider that instead of a bandage, I call sclerals basically an artificial barrier environment. They're creating this new barrier So when you have something like this is where a patient like this, I often tell them, I'm like, okay, I'm going to start you with the basics here, but the chances are we might be looking at something like scleral lenses for a patient.
Well,
like
and
this.
she had extensions on. She had all kinds of other stuff like HAP. So we had to do a multitude of things.
Yeah. So then here,
17.
yeah. So then in-office procedures, we'll kind of hit these really quick. IPL is great because not only is this going to help with the cosmetic side of things, basically the way I run through IPL is it's going to have multiple functions. The first thing that it's going to do is going to improve meibomian gland structure and function. So that's one of the good side of things. Originally, this came from the land of ocular rosacea, well, just rosacea treatment in general. So the light energy from IPL is going to be absorbed by the hemoglobin, by the pigment in the hemoglobin of our blood cells, and it's basically going to increase the temperature, and it's going to coagulate those spidery vessels. So one that's going to help with the cosmetic redness, but that's also going to help get rid of some of that inflammation that's leaking out of those vessels. It's also going to improve skin quality. It's going to be used to repair that sun damage. It's going to enhance collagen synthesis. It also can reduce the microbial burden, including Demodex and, in the bacteria, we get blepharitis. And just in general, it's going to be, we have no silver bullet, like Selena mentioned. There's not one thing, but the reason why I really like IPL is because it does hit multiple things at once. And then with this a lot, we have, so this is a patient of Selena's here. And how many treatments did you do?
This was only two treatments in.
And you can see here when you go from this redness from here all the way there.
Yeah.
And then radio frequency, this is one I've been doing for about a year now. This is a great tandem if you're looking at a dry perspective to IPL. But the reason why I like this is when I think of IPL, I also think this in terms of energy. So IPL, think light energy. This is thermal energy. But the reason why I like this is we've had a lot of thermal treatments. We've had LipiFlow, we have had iLux tear care. These are great. This one I like because this one lets us just be way more precise with the heat. So the way that this works, this specific protocol that we have that I use, so I use an OptiPlus, and it's 6 minutes. And the first 3 minutes, it uses a frequency that actually can basically concentrate the heat at the depth of the meibomian glands. So that's where you can really heat those well. The second 3 minutes is going to change the frequency, and it's going to target the skin of the lids. So that's where you're getting more of that bulking of the collagen. So to me, I say that's a 1-2 punch. First, you're melting the oil, and then you're improving that lid tone. So yeah, you get the cosmetic appearance that's basically improved, but you're going to have more powerful blinks. So you're now going to help with better meibum secretion. So it's a 1-2 punch. So again, you get all these cosmetic benefits, but you also get functional benefits. So I know I use them a bunch. I know they're workhorses in your practice. Then do you typically do them together, Selena?
Yeah. So I will do I'll do it as part of a series, but I use pretty high energies just because I've been doing it for so long. So often I will separate them because I turn everything up. I've got some pretty aggressive settings, but yeah.
Yeah. And then for me, I actually a lot of times, since most of the time my focus is very much on the dry side of things, I actually kind of go the opposite, where I actually turn the energy down, but I do more pulses with the IPL. Because for me, I'm focusing on basically just getting as much energy to the meibomian glands as possible while making it more tolerable. So definitely there's multiple ways to do this. And that's one of the great things I love about this. So it's, you kind of figure out which thing.
If you are going to do them side by side, like in the same session, just make sure you do IPL first and then RF second. Order matters greatly because with RF, if you create all that erythema, now you've created a whole lot of target and you're going to wind up over treating the patient. So order really matters.
And if you do gland expression afterwards, you want to do RF second because that's where heat comes from. You don't want those the oil cooling down between.
Question? Yes. I mean, they're not like super happy, but they're happy with the results, right? I do a ton. So her question is, how do you coach patients through, tolerability of the procedures? And so, I mean, I am a huge fan of verbal Valium. I mean, you guys know me, I can talk for like 5 hours straight. So I'm talking the whole time and distracting them. They have stress balls they're doing. I mean, I have one patient that says the F word on every single pulse.
I do too.
I have to make sure
let it all out.
Other patients are like on the other side of the clinic. I like the little vibrating tool. You can do that. If I'm, sometimes I'll tap on the opposite side of their head. You can tap on their shoulder. There's lots of ways that you can like kind of coach them through it. The only person I've never not been able to finish a session with was my husband.
Yeah, that tracks.
The only one in 9 years. No. Why would you not use lidocaine? You constrict the blood vessels. And there goes your target.
Yeah.
Great question.
Oh yeah. So this is a really good question we get. So the question is, how often do you wait, how long of duration between sessions? So 2 to 4 weeks.
Yep.
That's why I say about 2 is the earliest, 4, and it doesn't have to be uniform. That's why I actually like it, because sometimes a patient will be able to come in for a session 2 weeks between, but then they're like, oh, I'm going on a trip. I'm like, no, you're good. As long as you're in that 2 to 4 week window, you can push it a little bit more, but I'll say 2 to 4 weeks between. And I always say minimum, especially for IPL, minimum of 4. That's going to be my biggest thing I can say for that, because after the first 2 treatments, I even tell them ahead of time, you're not going to even know I did anything. Because for the vast majority of patients, I always say we have to build. So if you start down here and we need you up here, first one gets you 25% improvement, then you get about 50. So it's not till about the 3rd or 4th, because what happens is so often someone will do 1 or 2 treatments, they'll see no benefit, and they're like, I'm spending all this money, and then they just stop. And now no one's happy. You're not happy because they didn't get the entirety of their treatment. They're not happy because in their mind, they just paid for something that didn't work. So I always say minimum of 4 treatments.
Yeah, and package it so they don't really have an option.
Yeah, that's what I do too. And just tell them that's what it's going to take. And this is a great example, again, one of Selena's patients that you can see after radio frequency treatment.
RF only.
Microblepharal exfoliation, we'll talk a bit about this more with the lash health. So this is just a form of debridement. And then again, you can see here, before and after, getting rid of all those collarettes. Injections, I know Selena has kind of talked about this here.
Yeah, we talked about it. So just awareness is a big key there.
One of your patients here then too, I think is a really good example of just showing what they're kind of those lines that they're talking about a lot of times.
Because neurotoxin works great for dynamic wrinkles that you see like in motion, right? That's all that's showing. And then laser resurfacing is a fun one, like on the dark circles. Click one more and I'll show you the before and after on her. But this is a patient that came in for her glasses and contacts update, and on my questionnaire I have a thing about dark circles, and she's like, I would really like to not have these circles. Is there anything you can do? And hers are dark because she's got thinner skin and she has a lot of vascular pooling underneath. So when you have that vascular pooling underneath, IPL works great for that. And then if you can rebuild some collagen and get some more oxygen there, that's where the laser resurfacing comes in, and you're doing soft tissue coagulation. So she had an outstanding result. This is 3 treatments of each spaced 2 weeks apart. So I'll do IPL. I like to do laser first and then do IPL, because when you do laser, you create some things, and IPL cleans it all up.
Oh yeah, yeah.
And so that order again matters.
Yeah. And this is the one thing I want you guys to notice here is look how happy she is. That's the takeaway here. Is this is why if I could say the reason why we care about aesthetics is for this, because it matters to our self-perception, our self-confidence. So again, I always tell patients it's not vanity. How they perceive themselves is so much of that the physical side of things. So when we're treating this, I always think about this. This isn't some, frivolous thing that we're doing here. We are actually helping change people's lives the same way when we do with We Care for Their Vision, because we're helping them with their self-perception. So that's why for us, and I know with Selena especially, I tell everyone when I've talked to a lot of younger optometrist students, things like that, they always ask me, I'm like, well, what would you want to go in? I'm like, for me, it was dry eye. I knew that's where I wanted to go, but I'm like, if you have any inkling that you would want to do aesthetics in the future, learn everything you can right now, because we're the experts around the eye. Selena knew this when she was doing all of her training for this. We are as well equipped as anyone to be doing these procedures, because most of the people where they're getting them now, they have no training around the eyes.
Well, and they're not doing it. They won't touch someone right here.
Yeah, they'll tell you. Yeah, they're like, I don't mess with the eyes.
They put on goggles. They're not gonna do a scleral metal contact lens, and they're not doing anything on the eyelids. And so all of that area, there's such a niche of our expertise that you can fill just that, not let alone the rest of the face. Yes, question.
So here, for instance, in Nevada, if we don't have an eye provider that's doing the CO2 laser, what should we be looking for where we're sending patients?
So her question is, if we're not doing the lasers, how do you build a relationship with someone that does? So just like you would a cataract surgeon, you're going to find somebody that believes what you believe. You're going to understand how they're going to do the process. You're going to understand their training, and then how you're going to co-manage that together. So it's the exact same relationship you guys already have with your cataract surgeon. You're going to have it with an oculoplastic surgeon or a derm or somebody that you guys are going to work hand in hand with.
Yeah.
I have an OBGYN that he sends me a ton of dry eye and all this kind of stuff, because he's a functional OBGYN. He deals a lot with hormones and all of that kind of side of things. He doesn't do surgery anymore. So he's been and he's one of my patients. And so it's been a really cool referral pattern to figure that out. But yeah,
Last question.